TopMedTalk.
Well, hello and welcome to the second annual POCAPALOOZA, the Festival of Perioperative Care around the world. Because we can't travel and we wanted to bring the latest from around the world direct to you wherever you are and wherever you're watching from, we are here for you. And as we did last year, we are collecting donations for the African Perioperative Research Group led by the wonderful Bruce Pickard. You can find that link to the African Perioperative Research Group, or APORG, to, I believe, the right of the stage here. It's on the little box, and you can just click that button and donate. That is wonderful. Contribute to research over in Africa. Now, as I'm flying solo tonight, I'm reminded of the fabulous conversations that we had last year with our friends around the world, but especially in the Down Under. If you've missed them last year, you can look them up on TopMedTalk under POCAPALOOZA. But it's really my pleasure to introduce our next guest, and one of the gentlemen who I spoke with last year, a dear friend and forefather of perioperative medicine, Ross Kerridge from Newcastle, the Australian one, again with us here to share his wisdom and beautiful light. Ross, thank you for joining.
Thanks, Desiree. It's always great to take part.
It's wonderful to see you. And, we did this last year and reminded that we would be in person. And if we could, we would now. It's unfortunate, but we're making it work, right?
It's been a strange year, but we hang in there, and we're looking forward to getting together face to face eventually. But
that's right, whenever we can.
But in the meantime, isn't it fantastic what you and Monty and the others have done, providing such a great educational platform, both this session and all the other sessions. And I love that you've been so committed to the less supported countries as well. Including the APORG appeal. So it's great work.
Well, thank you very much. And Ross, I don't know if you caught it, but everyone who paid a ticket this year to EBPOM, part of that fee went to supporting people to register for free from underdeveloped and underserved countries. So we really kind of wanted to spread the love even more. And so, if you're listening or you're watching and you did buy a ticket this year, thank you very much, because you are supporting free medical education to the world.
Yep.
So
no, it's great stuff.
Well, Ross, last year we did a couple really amazing conversations with your colleagues and down there in Australia and New Zealand. And so I really want to direct everybody, if you didn't have a chance to listen, please go on the TopMedTalk platform and have a listen to those, and you can watch them on the EBPOM hub as well. But, I wanted to take some time. We kind of brought it down and pared it down a little bit because we all know we're having a little bit of fatigue for Zoom. But, it's always great to catch up with you because, traditionally at our EBPOM meetings, you always, have a lecture, a plenary, or you stand up and you give us words of wisdom and like I said, beautiful light and thoughts. And so I thought it would be great to catch up with you about that. You and I just offline have been talking quite a bit over, through the pandemic about what's happening, there and what's been happening here in the US. So I thought for our, viewers today that you could just kind of give us a little bit of update. It sounds like things are kind of moving a little bit. We heard from Paul Miles and he was saying, you've been able to really kind of keep the numbers down, but it sounds like things are changing a bit.
Well, the story in Australia, as probably many people know by now, it's been an extraordinary success, and I'm so proud of Australia and what we've done by engaging the whole community and practicing all the traditional public health manoeuvres of hygiene, hand washing, social distancing, and when things got out of control, locking down the community. And people have engaged with this. In fact, the population in general have been more supportive than some of our politicians, particularly at the federal level. But it's been an extraordinary achievement. And I think it's really emphasised the lessons that people learnt in the pre-antibiotic era. I know we talked about this last year.
We did,
the old things that our grandparents learnt when you didn't have antibiotics to back you up, that you cleaned thoroughly, put a lot of space between patients. You had fresh air, ventilation in hospitals, all the things that Florence Nightingale started with.
Yeah.
It still works. You've just got to do it.
You just got to do it. Do you feel like there's a little bit of complacency then, Ross?
Well, certainly that seems to be the story, that in Australia we've got complacent, particularly with the vaccine, and people weren't even bothering to get the vaccine or vaccine hesitancy. Currently, our national vaccination rate is only 4.5%, which is one of the lowest of all the advanced countries. And perhaps as a result, just in this last week, we've had some breakouts across the country, initially brought in through people coming from overseas and breakdowns in quarantine, because they're all supposed to go into quarantine. I think it's probably enabled some interesting research because we've got the capacity to do it. There's been extraordinary tracking of exactly what happens to viruses. And just last week, they actually managed to track a spreading event happening in a shopping centre with two people, one of whom they knew had COVID, and they've got it on the security cameras. And it's only just fleeting contact. Like literally, they're only standing near each other for about 30 seconds. And they know that's when the contact event happened, which is an amazing piece of science. The other exciting piece of science is from subsequent to that event, a child got infected. I think this is the details anyway. And they went to a birthday party in Western Sydney with 30 people at the party. 26 people got COVID. And the 6 who didn't had all been vaccinated. So, well, that is really exciting because it does show that it seems, really good evidence that there must have been some amazing super spreader going on, but the people who didn't get it had the vaccine. So the vaccine's good not just to reduce the disease, but to reduce spread as well. So that's really hopeful. But having done really well for 15 months, we're now having a breakdown. But hopefully we'll get back on top of it. And Sydney, Melbourne, Brisbane, Perth are all in severe lockdown, and some other cities as well. So.
Yeah.
Melbourne isn't in lockdown, but Sydney,
Melbourne's
Brisbane,
not.
Yeah, Melbourne's been a triumph. And the people in Melbourne have been so good about buying into lockdown.
Yeah. How are you guys, what's the discussion around Delta virus variant?
Oh, well, that's what's causing it. The Delta virus has got in, and plainly it's more transmissible, so it's going to be a problem. But again, it reinforces the old habits that our grandparents taught us of, wash your hands, wipe your nose, cover your face when you cough, get fresh air in the rooms and so on. But overall, and I know a lot of my friends and colleagues feel the same way, we've just been so protected in Australia, and we read the stories about what's happened overseas, and we just feel so lucky. It's great. I'm really proud, but there's an element of survivor guilt, I think, that what we haven't gone through. But hopefully we've shown the world. But I think around the world we all need to get together and say, what has this taught us about the way society should operate? And that we all have to work together in this and lots of other challenges we're going to face. Absolutely.
Yeah. Because this is, just one of many that we're going to have to go, and hopefully we'll have some lessons learned from that. So, well, Ross, it's always good to check in, about where things are in the space of perioperative medicine. Something that you've dedicated your entire career to, really. Yes. And I know you have your finger on the pulse of it there. Let's talk about some of the things that are coming out of Australia and New Zealand.
Yeah, there's a lot of interest here, and I know it's been included in the EBPOM program with Guy Ludbrook, but many of us here, and I know around the world, are faced with the issue of what we do about patients who are sick post-operatively, and they're too sick to go to the ward, but we don't have the resources to get them into intensive care. And you can even question whether a full-on intensive care is in fact the best place for them to go, because you put someone in intensive care and intensive things happen, and that's not necessarily what you need. Sometimes you just need a lot of careful nothing being done. Like that old quote out of the House of God, the best medical care is to do as much nothing as possible. And Guy in particular has been leading a project looking at developing alternative models for post-operative care and doing the economic analysis of it. Guy's an absolute demon on finances and economics and all that. But I think that's going to really inform that discussion. And so that's ongoing work that we're really keeping a close eye on, and I think will really change the way we do things. And then again, I know it's in the program for the EBPOM meeting this year, post-op pulmonary complications, and Antha Bowden, a physiotherapist, and her colleague Linda Dennehy in Melbourne, and Dave Story's working on this as well, and lots of others. But as you would know, I mean, the main message is that good instruction by physiotherapists in proper breathing technique, deep breathing, clearing chests, works to prevent pulmonary complications. And there's also the story about particularly patients with bronchiectasis symptoms that, again, physiotherapy does work. It's becoming a recurrent theme, isn't it? We're relearning the things that we always learned, always knew. Now, with the COVID thing, part of the response to that, as you know, has been telehealth. And that's really driven or reinforce the need to engage better with primary care. Both in Australia and New Zealand, our health system is based on, well, the ideal, or what's supposed to happen, is that everybody has their primary care general practitioner, as we call them, who coordinates all their healthcare, and then will refer them on to specialists as needed. And perhaps we haven't worked well enough with them as the whole perioperative approach to surgery has developed. And a lot of groups have been reaching out for those. The really interesting work has been, or some of the interesting work has been with Indigenous and remote communities. A lady called Edith Waugh up in Darwin in the Northern Territory has been doing some excellent work with linking in with Indigenous health practitioners, Aboriginal health workers in remote communities, and developing better links with them so that patients coming in from traditional communities are better prepared and more culturally prepared for what's going to happen to them. So there's been some really interesting work going on in there, which we'll be looking at further. Another thing, is the allergy delabeling. I'm not sure if you've heard of this idea, but Joe Triviano, an immunologist in Melbourne, has sort of led the field on this. But we've recognised that about 40% of new antibiotic exposures in hospitals are for surgical prophylaxis. Mm-hmm. So there's a massive amount of antibiotics being given, even if only for the first one or two doses, for patients having surgery. But they're not always being given appropriately. And sometimes because of inappropriate allergy labels, and patient has allergy to penicillin on their charts. So someone sees this, there's that old myth about, they can't get cephalosporins anyway. And then the surgeon says, we better give them vancomycin.
That's universal, Ross.
On the misconception that vancomycin is held back by those pharmacists and infectious disease physicians because it's a better antibiotic and they only want it for the really tough cases, which isn't, of course, the case at all. Some recent work showed that if you get second-line antibiotics, which for most people means other than a penicillin or a cephalosporin, you double your wound infection rate. So the thinking is that a lot of vancomycin exposure in particular for surgical patients is probably inappropriate. But how do we address this? And developing antibiotic delabeling or allergy delabeling programs. And a number of centres, including my own, we've been doing some work on this, and that's a bit of fun. And we actually give the patients a certificate saying that you are officially not allergic to penicillin.
Yeah, no, I have heard of that work, not called it that, but yeah, definitely, because we do. That's what people do. They give vanc, and we've just seen such a rise in vancomycin resistant and other antibiotic resistant bacteria.
Yeah, so interesting things going on in that. Now, our perioperative special interest group, which is a multidisciplinary, multi-specialty group, we've struggled with the COVID thing. That's disrupted our meetings, but we ended up having a very short one-day meeting last year, which we put together at short notice in frustration, but turned out much more successful than we'd expected. And we're lining up to have another meeting, again, still virtual, and again, the same frustrations, but 2-day meeting back to our normal timetable in August, and we're looking forward to that. Jill Van Acker's doing great leadership for the perioperative SIG. That's going well. But we're taking in a section on health informatics in under the umbrella of the perioperative SIG. That's literally just happening as we speak. And why is that? And we don't want to take too long today, but we might touch on this, that I think one of the really interesting challenges in where we go with perioperative care is doing much better about the way we handle health information. Mm-hmm. Because when we treat patients, we treat a physical patient, the protoplasm of the patient, if you like. But a lot of the time, what we're really dealing with is just the clinical information. And we do that appallingly, don't we?
It's terrible.
And I know that's not just Australia. I know that's all over the world.
It is universal as well. We just actually had a great conversation with Dr. Sam Ajizian about this, about how the access is terrible. And I know, Ross, one of the things that you do really well, and we have mentioned it in previous podcasts, you've been writing some opinion pieces, haven't you, for your local newspaper, and really, talking about the history of anesthesia and the history of the different things. And I think that's great. And one of the things, and I think this is where you're going with the technology piece, and not to belabor it right now, because we are on a little bit of a time crunch, but it's really how perioperative care is developed. And we do the reason why we're here is because we've taken this path here, right? History has led us here.
Okay, well, my trainees know that once you get me talking about history, you can write off the next hour. So we won't do that too much.
No, we'll do another podcast on this.
Yeah, for sure. That would be great. But jumping to the chase though, I think we've got, particularly in the last 10, 15 years, we've got on top of getting the process organised, and we're getting much better about the actual handling the patient and all this. And there's still a lot of challenges, but we've learnt that. But along the way, we're still handling the patient's clinical information. And Sam Ajizian from Medtronic, I listened to the talk after your prompting a few hours back. It's a great interview. But he's very focused on monitoring and doing much better with monitoring. And I think that's great work. But in the meantime, we used to say 90% of a medical diagnosis is the patient's history. And yet we handle the history so badly. And in my day, it was scattered through a ream of notes that thick. Nowadays, it's scattered through multiple databases which don't interact.
Click.
10 million, click. We call it CAP stalking in my health system, because CAP is the clinical application.
Oh, okay. I was like, is that some animal that you're trying to?
And we should be able to present it clearly, but then actually trust it.
Yeah.
And when we do this well, we should then change our behaviour. So rather than going in to see the patient and saying, "Hi, now what operation are you having?" Have you had any health problems before, or what other health problem, what medication are you on, which we do by habit.
Yeah.
When we do it well, we should train ourselves to walk into the room and say, Hi, I'm Ross Kerridge. I'm the anaesthesiologist. I'm going to be looking after you today. And look, I gather you've had a few operations before, and I gather you had a bit of problem with nausea and vomiting with the last operation. I've checked through the record, and that's okay. But the really interesting thing, I noticed that when you were a kid, you used to live up in Walker and you went catching rabbits or whatever. And that
I think they might worry about that.
But we can convey the message that we are on top of their medical history. Yes. We know all about them already. And we can just say now, okay, now look, just as a safety check, because we're focused on your safety, can you confirm what operation you're having? And reinforce that we do know. Well,
what the worst thing is, Ross, is when you have to walk into a room and you say, it looks like you had, you're diabetic, you have hypertension. Oh, you had a stroke in, 96. And I'm like, no, I didn't have a stroke. I don't know why that's on there, or no, I'm not on that medication. I haven't been on that in 10 years or whatever. I'm like, that is really just bothers me. And I love the reframing of how we interact with our patients. I think that can make a big difference.
Yep. But why don't we do that? And I think this is the challenge that we as, if you like, perioperative clinicians need to get together and agree on this. And that we talked about the protoplasm and the physical patient. And over the last, starting about 500 years ago, people actually started cutting people up and deciding on this is the anatomy of patients and describing it all and working out how it all works together and having a consistent way of describing the anatomy of the physical patient. And then 150 years ago, people said, well, it's not just the physical patient, there's the psychological patient. And we had people like Freud coming up with the id, the ego, and the superego. I don't know what that means, but it makes you sound intelligent. But working out, if you like, the anatomy of the psychological patient. And in psychiatry, when we're residents, you learn a mental state examination. You talk about the patient's appearance, their behaviour, their attitude, their mood and affect, their speech, their thought form and content, perception, cognition, insight and judgment. And it's presented in a standardised framework. And yet, when a patient comes for surgery, we haven't agreed on a standardised way of presenting all that information. And I've come up with this word. We talk about the protoplasm, and we now have the infoplasm. And it's all a mess at the moment, all our clinical information, and we all have different ways of presenting it, and that leads to things being left out or things being misclassified and so on. Yeah. And we should agree on, look, this is the way you present a patient's clinical information summary, and we do that consistently on every patient.
I love this, Ross. I mean, I definitely, we need to have more conversation about this because it is so true. And it does a disservice to the patient and to us, and if we can't, we can figure out how to, we sent somebody to the moon, for God's sakes, like, how many ever years ago, like we can't figure this out. And, getting the data and putting that in a way that is ease of use, for the provider. So I definitely, I think we need to talk about it.
So look, why don't we do it? That's an interesting question. And part of it is that we haven't all agreed on, let's say that this is the format that we will use. Yeah. These are the categories that we will use, and these are the standard data points. Cliff Coe and colleagues setting up the NISQIP database, they said, we want these data points. And I think they only collect, it's only 26 data points about that. And yet look at the power of what they do with only 26 pretty crude data points. And if we could just get a little bit more detailed about that, about the standard data points we collect on every patient, and collect them systematically and then crunch it into a NISQIP type system. Yeah. Just think of the power of prediction and prognostication that would provide.
Absolutely.
But there isn't a business model for it. And I think one of the other problems would be that if you introduce this system, the first person who has to enter the data has to actually sit down and devote a serious amount of time to getting it all crunched together and entered for the first time. And so they will take a big hit in terms of workload. But after that, everyone will say, oh, this is so easy.
Yeah.
And we have to work out some way, depending on which system we're in, some way of recompensing the first person to enter the data into the system.
Ross, do you guys use electronic medical records, right? You have electronic?
Well, depending on what system you're in. In my own hospital, we have a pretty patchy EMR, but it's more of a data repository than a fully functioning system. But actually, it's pretty good by international standards. And we use MedChart for electronic medication management, but we don't use anything electronic in the operating theatre. We still do it on paper.
Oh, paper.
As it happens, literally as we speak, I'm taking a sort of working holiday up in an outback town in Western Queensland.
I was going to mention that at the end.
yeah. And here we've got Queensland, which is one of our states, has a statewide electronic anaesthesia record system, which I'm struggling with. But their medications are all on paper. So,
oh gosh.
So it's patchy, and it depends which health system you're working in. So,
well, I will say that we changed over to Epic, and there are other. There are, I have to say, disclose, there are other systems out there, EMRs, but, it's really painful. It is painful anytime you start something like that, but I guarantee the people who complain the most about it, if you took that away from them, it would be terrible. So, I mean, it is a little frustration and learning curve at the beginning and time commitment, but in the end, it does help. And if we can make all those systems uniform, I think is what you're saying, and create these data points, I think it's going to be true. And I mean, the think of the future and AI and, all this, different things, I think is pretty cool. So, well,
so, and it comes down to us to agree to standardize. Do you know that a little piece of trivia to finish on? Do you know that until the mid-1930s, cars, there wasn't agreement on whether you should have the brake as the right-hand pedal or the left-hand pedal?
No, I didn't. I only thought that was something with the UK, like they could.
No. The pedals, the brakes.
Yeah.
That on some cars, the brake was the right-hand pedal, and on other cars it was the left-hand pedal. Can you imagine the amount of catastrophe that would have caused? God. And yet, it wouldn't really matter.
Yeah.
Whether you had it left or right, as long as you agreed.
Pick something.
And I think that's what we have to do, and we as clinicians should do it.
Yeah.
And so I'm really excited. As I said, the Perioperative Special Interest Group is taking in the health informatics piece and working on that or within our umbrella. And I think that's something that is a really positive step forward for the future.
Absolutely. Well, fantastic, Ross. I can't wait to hear more about that in the future. And as usual, it is always such a pleasure to chat with you and just muse and figure out what's going on in the world. It's great. I want to thank not only you, but thank dear Marion, your beautiful wife, for sparing the time, because you are, even though you are working, you're also on a bit of a holiday, right? A working holiday.
Yep. Preparation for retirement and
Yeah. So tell her, send her our love, because she usually comes along with you too on your meetings, and so we know her, and we really do appreciate you taking the time. And we'll catch up with you soon about the history of perioperative medicine. So the development.
That'd be great.
Okay. Right, much love to you. We'll see you soon. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.